Hello, welcome, good afternoon, good morning, wherever you're joining from. I will be speaking today live with Dr. Tortoriello, Medical Director at Sher Fertility Solutions, based in New York and also in Vegas. And we're going to be talking about, should I be scared of having IVF? We've had a couple of technical issues joining together today, so thank you for bearing with us. Here he is. Have your questions ready. The team at Sher Fertility Solutions have written a brilliant article. So head to our link in bio to read more, and we're going to be covering some of those commonly asked questions today. If you have any questions, please ask. Hello, hi, Dr. Tortoriello. How are you?
I'm good, Eloise. I'm good. Sorry about the technical issues, but I'm happy to be here and chat with you.
Absolutely. We are now live. People are joining. Thank you, everyone, for coming back. Please, could you start? I've given yourself and Sher Fertility Solutions a little introduction, but just tell us a bit more about you and what you do, and then we can talk a bit more about the topic at hand. Should I be scared of having IVF?
Sure. My name is Drew Tortoriello. I am the medical director at Sher Fertility Solutions in New York City. And I basically have been at this particular location for about maybe 12 or 13 years. Prior to that, I worked at Columbia University for about 6 or 7 years. I am a reproductive endocrinologist and fertility specialist. And it is a passion of mine, something that I've always been interested in and wanted to be a part of, and I'm fortunate enough to do so.
Amazing.
Yes. My partner is Dr. Jeffrey Sher, who obviously Sher Fertility Solutions is named for. Jeffrey Sher is basically a pioneer in the field of reproductive endocrinology. There may come a time in the near future when we get to chat with him also, but he is essentially done the seminal work in terms of a lot of the techniques that we use, and basically commonplace today in IVF and in ovulation induction. So that's sort of me in a brief nutshell. And I'm happy to literally talk with anything at all that anybody has an interest in with regards to fertility, infertility. I know we were going to talk a little bit about how IVF may seem to be, to those who have not done it or those who have contemplated, to be a daunting process.
Yep.
I don't think it's daunting.
Is that something that you see in your patients? Do most people feel apprehensive when you first tell them that they may need to have IVF?
Yeah, I think a lot of people do a Google search, and obviously, Google basically is a source of wonderful information, but it's also a source of, I think, some sensationalistic information, because that usually gets the hits and the clicks. So a lot of people do come in, and the last thing in their mind is doing IVF, and I try to give them the straight scoop with regards to what I think their problem is, what I think their problem needs to be addressed with. And more often than not, when IVF is on the table and when I go through it from A to Z, they realize, hey, this is not as problematic a situation as I thought. They were thinking they were going to be in my office every day for like a month, and a lot of intramuscular injections and a lot of medication. And sometimes there's a good amount of medication, but there's a whole gamut of patients that are out there that can get away with very little at times. So once you actually delineate what this particular person needs, I think they find that what's on the menu is something entirely palatable.
Absolutely. And so when you're seeing patients, at what stage would someone decide or discover that they may need to do IVF? Is it after a lot of trying to conceive naturally? Is it same-sex couples or solo parents coming in who sort of know this may be their option to create their family, or is it varying situations?
Well, it varies very, very much. I mean, the patients that I normally see that require IVF predominantly are couples who have been treated for years. I tend to specialize in very difficult cases, and I don't exactly know why particularly and Dr. Sher similarly, but we relish trying to help people who have cases that other people have sort of scratched their heads and said, I don't know if I can make progress. We look to help these people and make progress in these other cases. So we get a lot of people that maybe they've never done IVF and they need IVF, or people who have done a few IVFs and they've not had much success. We do have a lot of same-sex couples that need IVF, obviously for various reasons. But it's a road that nobody initially thinks they need, but when it's appropriate, it's better just sort of make up your mind and do it sooner rather than later, because even IVF, the efficacy goes down with time. So
Mhm.
when it's the right thing to do, it's probably better to do it sooner rather than later.
When my husband and I found out that we needed IVF, I think the sort of overwhelming feeling was, why us? I can't believe we have to do this. This is terrifying. But actually, as soon as we had a plan in place, and the motion started, it was relatively straightforward in terms of having our hand held and being guided through that process. So
Yeah.
in a way, it was kind of apprehensive, but also an element of excitement that this was the closest we had ever got to getting pregnant. And so each time we got past the next kind of hurdle, it felt like we have achieved, we'd got somewhere further than we'd ever been before.
Yeah, it's true. I mean, just strictly in terms of statistical efficacy, IVF beats all treatments. You know, really, no matter what age you are, IVF is always the best in terms of the stats. But the good thing also about IVF, I find a lot of people are appreciative of, is the fact that IVF is somewhat diagnostic. Because when you do other treatments, you can inseminations, for example, you don't exactly know where the process went awry. You try to get the timing right. You look at the sperm count. You place the sperm, in intrauterine position. But thereafter, you don't really know what transpired. You don't know if the sperm got to the egg, know if the sperm got to the egg but couldn't penetrate into the egg, know if that, subsequently made embryo developed well, and if it developed well, was even chromosomally normal. Did a chromosomally normal embryo make its way into the uterus, but you have an implantation issue? It's never been an embryo issue.
Mm-hmm.
So you get an implantation issue. With IVF, God willing, you get pregnant very quickly and easily. But if you don't, at least IVF will tell you somewhere along the way, you're gonna reach an impediment, and you're gonna likely be able to identify the impediment and focus your efforts directly on that little blockade. So there's some solace, at least in knowing that I made some progress, at least in understanding what my particular issue is, if anything.
Mm-hmm, definitely. And I was just explaining to people before that you and the team have written the most fantastic article outlining these steps and considerations and, just any qualms that people may have about fears around being diagnosed with a fertility issue or needing to move forward with IVF. So please head to our link in bio to read that after our talk. It's a very, very good article. We've had some questions come in live, which I'd love to ask you, and then we have some other bits to discuss, if that's okay.
Sure.
So this lady's had a miscarriage last year, I'm so sorry, and has not received or sort of returned their mental health. They're now on birth control. Can you share any thoughts? What are your thoughts? This is actually one of the topics, one of the things that I wanted to talk with you about. Support, sort of emotional support, if treatment doesn't work first time. What are your thoughts on that, and what's available?
Well, there's the doctor to begin with, and the doctor should always have a conversation with the patient after the procedure to say, this is what I liked about what we did, and this is what I'm disappointed or a little bit frustrated about what happened when we did what we did. So the patient has some insights as to what you're thinking. They don't want to be guessing what's going on in your head, because that just creates anxiety. So whether it's a good outcome or a bad outcome, you have to have a follow-up, I think, fairly quickly, and just say, here's kind of what happened, and these are the directions I think we need to go into. Because there's a lot of comfort in knowing that you are moving in a hopefully positive direction and learn something. So I always had a problem with it when follow-up consultations were booked like a month and a half out for some doctors.
Yeah.
Because meanwhile, you're stewing at home wondering, oh my goodness, where are we going to go? What's going on? Time is wasting. So it starts with a physician, I think, number one. But number two, I mean, there are a lot of specialists out there who are trained psychologists or social workers or psychiatrists, and simple, support groups that you can be a part of to just get some sort of, I think, clarity and some consolation and some empathy, which goes a long way in this world. Because basically infertility is kind of like you're every single day you're not pregnant, it's kind of like you're mourning. And if you have somebody you love and they pass away, you mourn, and then gradually you make your way through it. But if you are trying to get pregnant for 3 years, 4 years, 5 years, every single day it's a sense of mourning, you know. And some people handle it remarkably well, and other people understandably need a little bit more help. So I have a network of people that I work with that I think are very, very good for this. And it's completely and utterly understandable that you feel depressed and you feel disappointed, and it's hard to see, you know, the end of the tunnel. But more often than not, I'm happy to say that there's some light there. You just got to know
I'd love,
what to look in.
I'd love to know, you know, as a specialist with so many years experience, when you see a patient's results before they've been called or told, you know, that maybe a cycle hasn't gone the way they wanted, how do you handle that conversation?
It's a very tough conversation, and you know, sometimes we have patients that say they want to be emailed, so we email them. Sometimes patients want to have phone calls. I try to reach out to them at some point during the day. Very often they'll kind of beat me to the punch, because while I'm seeing my patients, they'll call and they'll speak to a nurse, and my nurse will tell them, and then I'll follow up afterwards.
Yeah.
But I tell them, I basically give them a mini preview of what I would give in a more formal consultation thereafter, that basically, even though things didn't work out the way we wanted them to work out, I focus on the good. And the good is that maybe we got a normal embryo, and before they didn't get a normal embryo. Or maybe they'd never implanted and now they did implant. You know, just, or if things didn't go our way, then maybe we want to do additional diagnostic testings for the more arcane, sort of obscure problems that we don't necessarily screen everybody for initially. So basically it's constellation with a quick view to the future.
Yeah. And do you feel like you can learn a lot from a cycle that hasn't worked?
I think so. I think so. I think you can always tweak things a little bit here and there. You can find a way to do things a little bit, you know, every woman is idiosyncratic. So just because you pick up a plan and you think that this particular protocol is ideal for this particular woman, you know, there are women that will respond idiosyncratically better to higher stim, to less stim, to longer stim, to no stim. And you don't know that from the very beginning. You make your best guess based upon your experience in this field. But you learn, and hopefully you learn in a way that makes life easier for the patient going forward.
Absolutely. There's another question that's come in, please. Someone has asked, is it imperative to manage your thyroid before starting IVF?
It's very important to do so. I wouldn't say that it's crucial. Is if your thyroid gland, if you find out you're a little bit hyperactive, a little bit hypoactive, does this mean it's a deal breaker? Probably not. But there are studies that basically show that the women who get their best outcomes have all of these hormones essentially in smack dab in the middle of the normal range. And with thyroid, we've recently gotten a lot more stringent, you know, in terms of what we consider to be normal. Almost to the point where it seems like 50% of all my patients are quote unquote hypothyroid, because we've now made this, you know, this range of perfection so narrow that we really got to target the thyroid hormone repletion very, very well. So I would say yes. And obviously we screen everybody for it. We treat them as needed for it. And we monitor their response to the medication every 3 or 4 weeks.
Okay. That's good to know. And are chances of success with IVF lower if someone has premature ovarian insufficiency?
Unfortunately, yes, because the factors that determine whether or not somebody is going to get pregnant with IVF are basically their quantity of eggs and their quality of eggs. And if you have premature ovarian insufficiency, the quantity of eggs you're going to be getting is going to be likely considerably lower than what you would otherwise have been able to get. Now, I'd rather have 1 or 2, if I could have my way, and, you know, make a bargain and say, I'm going to get 2 eggs every time from every patient, but they're going to be 2 normal eggs every time, versus I'm going to get 20 unknown eggs from my patients and not really know what they're going to be in terms of quality. I would always emphasize quality over quantity, because usually that's the rate limiting step in terms of making a baby. So you don't necessarily need to get fixated on numbers, and I don't, But unfortunately, that's a facet of premature ovarian insufficiency where you're working with less to start out with. Each egg is kind of like a lottery ticket. So the more tickets you get, theoretically, the better the chance.
Mm-hmm. Do you find that when you're seeing patients, you mentioned this before, that patients may sort of have Googled things, so by the time they come back and see you and you say, oh, you know, you've got X follicles, or this is how things are looking, they've almost, not self-diagnosed, but they've already almost sort of anticipated what their results are going to be before it's even happened, even before egg retrieval stage?
Yes, I have a lot of people that come in. I mean, some of them come in and know very, very, very much to the point where I'm thinking about hiring them to be one of my clinical coordinators.
Yeah, they're so well read.
Yes, because they're
Yeah.
incredibly well read, but more importantly, they have the wisdom of having gone through it a couple of times. But you always need a tempering voice because women unfortunately tend to focus, not all of them, but a lot of them tend to focus on the negative aspects. You know, I don't have as many eggs as I should. Sometimes it doesn't really matter all that much, like we were just talking about quality and quantity. You know, women who are a little bit on the younger side, maybe you get 2 or 3 or 4 eggs, but their quality is better because of their age. So you need to be there to, I think, complete the picture. Google is a blessing and a curse. You know,
Yeah,
that's what,
definitely.
like people like you and me come in to provide information.
And I got lost in a rabbit warren of reading, and this is why I do what I do and set this up, because I just was reading blogs from about, you know, 100 years ago where people have these random names and you read someone else's outcome and then you think you compare it to yours, and
Mm,
obviously no two people are the same, and it doesn't show you what your result is going to be at all.
yeah. I mean, I have a lot of people that tell me, well, I have a friend who's doing IVF with so and so and she's on this medication. Why am I on that medication? Or she's triggering with this, why am I triggering with that? Or you know, then you actually have to you have to basically find out the history of everybody and
Yeah, yeah, exactly. Another question that's come in privately, PGTA for a 34-year-old, what would your response be to that without having seen their medical records?
PGTA for a 34-year-old. Um, it depends to a certain degree on what their diagnosis is. For example, if there's somebody that's got a history of recurrent miscarriage and we don't really understand why, then I think PGTA for this sort of younger age range makes sense because the main reason for miscarriages would be, you know, chromosomal abnormalities in the embryo, and you can abrogate that risk by doing PGTA for the most part. So that's obviously kind of the impetus is there to do PGTA. But if you're 34 years old and you're doing IVF because you have blocked tubes or your husband's sperm count is unfortunately very low, then you probably would have a pretty good overall egg quality, sperm quality, embryo quality. And, you know, maybe blastocyst is roughly a 50-50 chance of being normal. So then it's not as crucial. And I would offer it and say, you know, this is what we do. We can offer this to you if you want to take it up. But certainly I don't think there's a very strong motivation for it.
Is it something that you would less likely suggest people do if they're using a donor?
Again, same thing. I would tell people that you're superb quality eggs. The odds of any particular blastocyst making a baby is at least 50-50. You know, days gone by when we were a little bit more aggressive in the IVF world, we used to put back 2 embryos at a time. So the pregnancy rates were very, very high. We've been putting back 1 at a time, and we're basically getting almost identical pregnancy rates with 1 versus 2. And I think the data is out. So I give people the benefit of knowledge. I tell them we can do all of these things. And for you, I kind of feel better about doing this or avoiding this. But some people want to do it because they want to minimize the risk of miscarriage
Mm-hmm.
quite a bit, or they like the idea of being able to tell their OBGYN, I don't really want an amniocentesis because I think I'm very low risk because this was a PGT normal embryo. So they want that information. For very young women, for donor, I don't emphasize it. I mention it. I offer it, but I don't promulgate it as something which I think is necessary as part of the treatment.
And what about using a sperm donor?
For what purpose?
For example, my husband and I have children through a sperm donor. He's infertile, and 5 years ago, 6 years ago, when we created our embryos, we
Mhm.
no one talked to us about PGTA, and I don't know whether that's because things have advanced now in terms of that being something that happens frequently, or whether because we were using a sperm donor and the issues that we were facing on my husband's side, whether it was felt that perhaps the embryos therefore didn't need to be tested.
Well, supposedly, I mean, if you're getting donor sperm, presumably you're getting it from somebody who's young, who's been proven to be healthy. Very often they've, as part of their file, you know that they've successfully fostered a pregnancy with their sperm.
Mm-hmm.
So I would not consider that to be an indication per se that would raise my, you know, interest in doing PGTA, especially.
Mm-hmm. Mm-hmm. But because if the sort of issue, I guess, has been on the male side, and then a donor's been used, I guess, would that make you think that perhaps the egg quality, or the genetics on the egg side
Would be
would
better.
be sufficient to not need to do PGTA?
Yeah, I think that's a valid point. It depends on how young the woman is when you're doing the
Mm-hmm.
process. If she's in her, mid-30s or younger, and I think you could feel comfortable without doing the PGTA process,
Mm-hmm.
you know? And PGTA, every single month, it seems like there's a new level, there's a new nuance to our understanding about PGT. Papers have now been published where, one particular center in New York City has been transferring PGT abnormal embryos that other places don't want it to transfer. And they're not really getting very high pregnancy rates at all, like 1 or 2 or 3%, out of like 100, maybe 1 or 2 women will get pregnant. But, that also adds nuance to your understanding of PGT, because PGT is not infallible.
Mm-hmm.
Have an embryo that's, deemed abnormal but makes a baby, and vice versa. So I think the main thing is informed consent. You have to talk to people about what PGT offers and what it doesn't offer. I think
Mm-hmm.
there's a lot of places in the city now that actually mandate it. It's like we only do PGT, and
Right.
I think they do that out of kindness because they believe they're sparing women, some sort of heartache that may come from a miscarriage or things like this. But we need to be cautious about how dogmatic we are in our approach towards PGT, because data is coming out every single day, its detriments and its benefits.
Mm-hmm. Absolutely. Linda has just said, and I'm sorry, you're sort of going through the situation that my husband and I went through. Yeah, that he's been diagnosed with azoospermia, and you're feeling overwhelmed. He doesn't want to talk. My husband was exactly the same, and IVF is something strange for him. Or I don't know if you both feel like that. What's your advice, Dr. Tortoriello, about next steps when you have a diagnosis like that? And I'm sure you've seen this a lot. What
Mm-hmm.
do you advise people to do in terms of sort of regrouping and making next steps, or contemplating options?
I think the first thing you need to do is get a little bit more information about the azoospermia. I mean, the right thing to do, I could talk about it, but the right thing to do is to see a urologist, especially a reproductive urologist, who basically all that particular physician does is handle gentlemen with fertility issues. Sometimes you find that there is sperm to be had, but the sperm is just not making its way into the ejaculate. Sometimes gentlemen have problems with what they call retrograde ejaculation, where the sperm during an orgasm will actually go essentially retrograde into the urinary bladder rather than come out and ejaculate. And you can actually retrieve sperm from the bladder and use that sperm for your fertility. Other times there will be a problem with the maturation of the sperm, where the numbers will be so low, but the urologist can actually do testicular biopsies and get some sperm from a very small testicular sample. And when you're doing IVF, you have to remember you don't really have a lot of sperm. I mean, you're physically picking up one sperm and injecting that one sperm into one egg. So whereas if you're trying to get pregnant with insemination or with natural intercourse, where you need tens of millions of sperm, theoretically, if you have 15 eggs, you need 15 sperm when you do IVF. So number one, there may be sperm to be had. It may be a bit of a process, but a lot of the times I find that's the case. If there is genuinely azoospermia, there's no sperm whatsoever, obviously it's a heartbreak. Nobody wants to hear that news. And then you have to, I think about various choices. Obvious choice number one is to use sperm from a sperm donor. Some people don't want to go that option, and I totally understand that. Other people feel more solace in embryo adoption or just adoption in general. But the right thing to do is to make sure that you have exhausted all possibilities leading to your own sperm. And I think at least 50% of the time there's some sperm to be had.
And if sperm is found, because my husband had the micro-TESE operation and it wasn't successful for him, he has Klinefelter syndrome and only found that out when we were trying to conceive, and hence the azoospermia. We were told at the time that if the urologist was to find sperm in the testes, that it may not be, well, they did in fact find some, but it wasn't advanced enough to fertilize my eggs. So they watched it in the lab overnight and it wasn't going to work for fertilization. Is that something that you've seen before as well?
Yeah, obviously if you're getting sperm from the testes, you're going to get a range of maturation in terms of the sperm. If the sperm is very, very immature, then it's just not going to fertilize the oocyte, unfortunately. And yes, I've seen good outcomes. I've seen, unfortunately, sad outcomes when you do the testicular biopsies and the testicular aspiration. Sometimes, unfortunately, you don't have the luck that you need because you won't find a patch of sperm that reached that developmental stage where you can use it efficiently.
Mm-hmm. And someone actually privately has just asked your thoughts on a fresh cycle versus a frozen cycle. And that ties in with this a little bit, because if someone is having an operation in advance to, for example, try and find sperm, or they may have had a failed cycle before, do you think it's better to sort of go straight into a fresh cycle and have a transfer at the same time? Or do you advise patients to have a frozen transfer? What normally happens at Sher Fertility Solutions?
Well, I find that most of my patients want to do PGT. So I'd say probably about 65–70% when I go through everything, they want to do PGT for whatever reason. And at this point right now, that necessitates a frozen embryo transfer because it takes time to get the results back. Are the embryos normal, not normal? And if there's something normal, then you move into the frozen transfer. So let's say that we're not interested in PGT. Should we do a frozen transfer regardless? And there are places that will only do frozen transfers because they believe that you get a more receptive endometrium in the context of a more natural uterine environment rather than a uterine environment that's been under the influence of all the stimulation medications. I think that's a valid point. So if I have somebody who I think is a very high responder with very high estrogen levels, number one, if they get pregnant, there might be a risk of hyperstimulation, which is good to avoid. But not really at that risk level. There's still some studies to suggest that the ratio of estrogen to progesterone in these high responders throws off the lining receptivity such that it might be better waiting for a frozen embryo transfer.
Yeah.
But if I have somebody who's basically a middle of the road or a low responder, their lining is the right thickness, they don't have premature elevations in their progesterone during the stimulation medication, and they made up their mind about doing chromosomal testing, that I'm okay with doing it. I mean, years ago, we only did fresh transfers because there was a reticence to freeze anything because the technology for freezing and thawing was not. Now freezing and thawing, it's like almost 100% survivability of the blastocyst that we freeze. So I don't blush at that idea if we have to do it. But if we want to do fresh, I'm happy to oblige.
That was actually one of the points that you guys wrote about in the article, which is a really good one. It's egg retrieval. Will it hurt? And I know from experience, having had two, it's manageable. But I think the first time I had, how many egg retrievals? Both times had a fresh transfer. First didn't work. Then I had a frozen embryo transfer that did work, resulted with our daughter. Then had a fresh round and transfer of two embryos 11 months later, which resulted in our twins. So like you said, this is back at the time when 2 blastocysts were sort of okay, if you like, to transfer, and I think that rules have changed around that a bit. But I remember being worried having that fresh transfer, thinking, I'm still in a bit of pain from the egg retrieval. Is my body ready to accept these embryos? And I was worried that I wasn't in the best form I could be. But actually, that cycle did work.
Yeah, I mean, obviously, the consideration is how are you going to feel if you get pregnant if you're already bloated and not quite yourself? Because the pregnancy hormones might exacerbate the bloating and the pressure and some of the symptoms that you're not really enjoying. But, you know, if the lining is receptive, whether you feel like a champion or you don't feel too great at all, if the lining is receptive, there's a very good chance you're going to get pregnant. If the embryo is a very good chance you're going to get pregnant. So I think if you're not feeling very, very well, then you should probably consider doing a freeze, because if you can avoid the first trimester of your pregnancy being incredibly uncomfortable.
Absolutely. Absolutely. That's great advice. I'm aware of your time, and thank you so much for answering everyone's questions today. Please do get in touch with the team. I've linked up the article in our bio, and you can speak to the team there. Through that, read everything we've just discussed around how long a cycle lasts. What if you're scared of needles? How will the meds make me feel? Will I be irritable? May I be depressed? Will retrieval hurt? What medical support is available during treatment? What happens if it doesn't work first time? So all of these brilliant questions have been answered by Dr. Tortoriello and the team at Sher Fertility Solutions. So I really would say, please head to our link in bio to read more, and do contact their team because they're fantastic. And where are you located in New York? Please could you tell everyone watching today?
We are in Midtown in New York City. We're at 425 Fifth Avenue, at the corner of 38th Street. Not too far away from where Lord and Taylor used to be, and not too far away from the Empire State Building.
Perfect.
I just would like one quick thing if I have the chance. I don't know if
Please do.
We are going on a different topic. We're going to be doing a study at Sher Fertility for ovarian PRP. And maybe that will be a topic, I guess, for another day. But PRP is platelet-rich plasma, which basically is a product from your own blood that's very high in platelets, which are cells that secrete a lot of growth factors. You probably heard of ovarian rejuvenation out there if you've been Googling, where doctors are injecting PRP into the ovary to try to get the ovary to produce maybe more eggs or better eggs when they do IVF. We actually want to, before we make a big commercial, to do over it, we really would like to understand a little bit better. I think we could use some more data points on it. So we're actually, for people interested in the study, for people who are willing to do, or who know they want to do or have to do 2 IVF cycles, we are doing ovarian PRP in between cycle 1 and cycle 2 of IVF. And we want to see if there's a difference in the quality, number of eggs between the first cycle and the second cycle. And for people who are interested in doing this, if it suits your particular fertility needs or goals, then as compensation for you being a part of it, we're not charging you at all for the PRP. And there would be a 25% out-of-pocket discount on the IVF, basically because we want to do good IVF, but also we want to advance the field a little bit, get knowledge about this, because I think right now patients and physicians really need to, I think, come together with a little bit more clear and concise information about it. So I would love to partner with anybody who's interested and has the need for something like this. I think it could do good things for everyone.
That's amazing. Amazing. So please do contact the team at Sher Fertility Solutions. They can tell you more about this wonderful opportunity, which of course will help so many people and will be a huge advantage to anyone who wants to give it a go in terms of the discount on the treatment too. So you can DM the team. We're happy to introduce you if you want to message me. And the link is in the bio to read all about this, everything we've been discussing today and more, and to contact their wonderful team. So thank you so much for your time today.
Thank you. I really appreciate your time, Eloise. Look
Lovely
forward.
to see you on for the next one soon.
All right,
Bye-bye.
guys.
Bye-bye.
Bye.
Bye-bye.